We will continue the reductive adaptation onwards, page number 20, chapter 27, page number 313 onwards. Reductive adaptation at marasmus, which means how the child's body adapts when it is undergoing malnourishment for survival. Okay, certain physiological changes will take place within the body to keep the body alive. Okay, so during the event of any reduced intake of food, which means malnourishment, okay, energy needs of the body is met by making sure that other tissues which has fat reserves, protein from the muscle, skin, and gut, they all are mobilized. Okay, mobilized for the breaking down and using it for the body survival. So this is what we call as reductive adaptation. You reduce what is available in your body to adapt for survival. Okay. So energy consumption occurs by reducing the physical activity. The child will not play a lot, move a lot. Okay. Will be lying just resting. Okay. And growth will also not take place. That's why we see stunting happening during malnourishment. The second pathway is reducing the basal metabolic rate. Basal metabolism slows down the protein turnover as well. Okay. And also it reduces the functional reserve of the organs, reserve of protein and fat, which was there for the organs to use. That is also depleted. Sodium pump, potassium pump also in the cells will reduce in number. So electrolyte imbalance will also begin. Then reducing the inflammatory and immune responses. For inflammatory and immune responses also, energy is required. When there is no energy, okay, for these responses to protect the child's body, the child is more prone to inflammatory reactions and immunity issues, infections, recurrent infections. It will take over the child's body. So this is what happens during reductive adaptation. Next, there are certain consequences of reductive adaptation, even though reductive adaptation is taking place to keep the child alive, okay? But there are some pathophysiological consequences that will happen within the body. So what are these consequences? In your liver, what happens in the child's liver? It is not able to make glucose and it is less able to excrete excess dietary protein as well. Okay, gluconeogenesis will stop in the liver. Okay, liver will not be able to make new glucose and it will not be able to excrete dietary proteins from itself as well. So the liver function will be deprived. In kidneys, what will happen? The kidneys are also not able to excrete excess fluid and sodium because kidneys are saving as much as fluid and sodium for the future use. The kidneys know that the child is undergoing starvation, malnutrition. That is not much for the child to survive on. Okay, so the kidneys will also stop or reduce how much it is supposed to excrete. Heart, the child's heart becomes smaller. Okay, the muscles get weaker over time and the cardiac output also reduces. In the gut, the stomach and the small intestines and all, they will produce less acids, less enzymes, okay? And also the intestinal villi that is supposed to, that finger-like projections that are supposed to absorb the nutrients, they become flatter and flatter. They become shorter and shorter in size. They're supposed to be long in size, elongated in size, but they become shorter and shorter in size. Sodium will leak into the cell and that leads to edema, okay, water retention, water imbalance. Iron is also liberated. RBCs will break down, red blood cells will break down, and it will lead to anemia. Iron will be liberated from the red blood cells, and it will not be stored properly in the liver, spleen, or other parts of the body. And it can become sometimes this free iron, which is in the blood, that could act as free radicals and cause more damage. Then muscle mass reduces, lots of intercellular nutrients, glucose stores from the muscle mass is also lost. Then infections, immunity, since it is low, immune responses are low, the child is prone to more and more infections. So these are the consequences that will happen. What is fasting adaptation? Okay, what happens in this fasting adaptation? One is reductive adaptation and another is fasting adaptation. So if the child is not eating or starving, okay, initially fasting adaptation will come into play, and then it goes into reductive adaptation, etc. Okay, so this adaptation will depend on the differential energy sources. In a newborn baby, it is different. In a child, it is different. In a toddler, it is different. Okay, with age group, the fasting adaptation will also differ. Based on the child's birth weight, gestational age, okay, the fasting adaptation differs. So a normal child who has this fasting stage, which is what we call as hypocatabolic stage, okay, what will happen here is usually when there is starvation, initial response is that the body will switch from carbohydrate metabolism to fat metabolism. Okay, fat in the body will be broken down sooner, and then carbohydrate will be saved for the brain's use. Usually, and after that, the carbohydrate stores are depleted, and within 2 days, again, still the starvation continues. There will be new gluconeogenesis from amino acids that are from proteins and glycerol. Proteins will start to break down. Ketogenesis will happen. Ketogenesis means in absence of carbohydrates, when fats break down, ketones are the byproduct of this action, this chemical action in which fat is broken down to give energy. So a lot of ketones are produced within the body, and they will be circulating within the in the blood as well. And this is in this consequence, insulin also decreases, cortisol increases. When does cortisol increase? Otherwise, when you are under stress, under severe stress, when you are under any oxidative stress, okay, during any inflammation, okay, cortisol levels are increased. So same cortisol level increases during fasting adaptation as well. Protein catabolism begins after all this stage. Fats have been utilized up, carbohydrates have been depleted. Now, what is left? Protein. Okay, protein from your muscles, other parts of your body. Okay, so after prolonged starvation, protein catabolism will begin, resulting in degradation of important protein. Okay, and organ system dysfunction also will take place because every organ is made up of protein. So once the muscle proteins are used up, what is left? Organ protein. If that is also used up, it will lead to systemic failure, organ failure. It may lead to death as well. So this is about fasting adaptation, initial stage. Coming to the physiochemical and hormonal mechanisms that takes place in adaptation. First is the cortisol. Cortisol is a major catabolic hormone in the body, which means cortisol will break down. Okay. When you are stressed a lot, when you undergo chronic inflammation, a lot of cortisol is released in your body. And this cortisol is a hormone that will break things down. It can break down the protein in your body and make you look older than you are. Okay. It will lead to the loss of lean muscle mass. Okay, so cortisol is a hormone that causes more breakdown if it is released in high quantity. It also has anabolic effects, especially in carbohydrate metabolism. Cortisol helps to maintain the blood glucose levels, also amino acid level, and fatty acid pool. But too much of cortisol, if it is released, it will lead to the it will increase the gluconeogenesis from amino acids, which is bad because amino acids are proteins. Okay, if glucose is coming from proteins, means proteins are getting broken down. It increases proteolysis, breakdown of protein, and it decreases protein stores in your body. It mediates lipolysis, that is fat metabolism. So fat is also broken down from your body, even the subcutaneous fat which is just under your skin. Okay, that is also broken down. Any type of stress, trauma, or infection will lead to the secretion of cortisol, as we have seen. And pituitary gland mediates the release of cortisol. In malnutrition, it is response, the release of cortisol is because of the response towards stress, infection, gluconeogenesis, etc. In kwashiorkor, cortisol is not high, that much high as compared to marasmus. Insulin, again, it's an anabolic hormone, which means insulin does the opposite of what cortisol does. Okay, insulin promotes the utilization of glucose, so it tries to safeguard fat and protein within the body. And in terms of carbohydrate metabolism, insulin will help the glucose to be transported and utilized within the brain cells, other tissues as well, so that the energy requirement should not come from fat or proteins. When it comes to protein metabolism, insulin makes sure that along with growth hormone, there is an increased uptake of amino acids and protein synthesis, so that the protein is not breaking down, since protein is being synthesized. More proteins are being formed. When it comes to fat metabolism, it prevents lipolysis. It has a fat sparing effect. Insulin promotes carbohydrate metabolism, and it tries to safeguard fat and protein. So it prevents lipolysis. Lack of insulin will lead to too much of lipid utilization. And if too much of lipids are being broken down, that could lead to fatty liver as well. Regulation of insulin. So sugar levels play an important role in regulation of insulin. If your blood sugar levels are high, there will be high insulin secreted. If the blood glucose levels are low, insulin will be secreted. Apart from that, amino acids like arginine, lysine, hormones like your growth hormone, cortisol, they can also stimulate the release of insulin whenever it is required. Growth hormone, when the starvation and protein depletion is at its peak, growth hormone secretion increases. It tries to conserve carbohydrates, increase protein synthesis, and increase the fat metabolism. That is the role of growth hormone, to protect protein as much as possible. It conserves the glucose that is the effect on carbohydrate metabolism, but it also increases glycogen production. When it comes to protein metabolism, the growth hormone makes sure that more protein synthesis is done, which is more protein is being made out of amino acids, so that protein is not utilized by the body for energy. Protein is being made within your body, not utilized for energy. not broken down for energy. Then effect on lipid metabolism, it leads to lipolysis. Growth hormone will try to break down the fat for energy requirement. Somatomedins like A and C, they are also insulin-like growth factors. Again, in kwashiorkor, their secretion is reduced, but in marasmus, more somatomedins are released. Glucagon, generally normal in these malnourishment cases. But again, the secretion of glucagon is also varied in the number of alpha cells that are present in the pancreas. Glucagon, as you know, functions just opposite to what insulin does. The glucagon will increase the blood glucose level. Insulin will try to reduce the blood glucose level. So if you have more alpha cells in the protein in your pancreas, more glucagon will be secreted. If the child does not have enough alpha cells in the pancreas, glucagon will not be secreted. Then thyroxine, usually it may be low if there is a malabsorption of iodine, just like any other nutrient. Conversion of T4 hormone to T3 in the tissue is also decreased. And that is also one of the reasons why it leads to low basal metabolic rate, because thyroid hormone, it helps with your basal metabolic rate. And if the thyroid production is decreased, automatically your basal metabolic rate also comes down. Coming to disadaptation in kwashiorkor, it's on page number 319. Disadaptation in kwashiorkor. What happens in kwashiorkor? What happens within the body of a child who has kwashiorkor? Catabolism is not to the same extent as marasmus. That is the reason why you see a marasmic child and a kwashiorkor child. In a child who suffers from kwashiorkor, they have this edema throughout their body. But in marasmus, they do not have edema. They have sunken in, they have lost their fat, they have lost their muscles. So they have undergone a lot of catabolism. Catabolism means breakdown of your own body part for survival. So that is high in marasmus. But in kwashiorkor, it's not that high as compared to marasmus. But anabolism is low, even though catabolism is not to the extent as in marasmus, but anabolism is low. Anabolism means synthesis of new fat cells, okay, synthesis of new proteins, okay. These things are also low, even though breakdown is not happening that rapidly, but the synthesis of healthy proteins and fat is also not happening. So because of which homeostasis is not maintained, okay? Because a breakdown is not happening, but synthesis is also not happening. So there is an imbalance, okay? When breakdown is happening and synthesis is also happening, something is being broken down and something new is being made by these broken pieces. So balance is there. But here, the breakdown is not happening, but nothing new is getting made by the broken down pieces. Okay, so what happens? Disbalance is created, and because of this disbalance, because the homeostasis is not maintained, okay, fatty liver, edema, okay, this will begin in kwashiorkor cases. Even the essential amino acid pool, that is also low in because of anabolic hormones, including insulin-like growth factors. Okay, somatomedicine, these all are low. Anabolism is low. So essential amino acid pool is also present there as it is, but not being utilized. protein synthesis is also low, and the mobilization of fatty acid from subcutaneous tissues directly, it will be taken up from the subcutaneous tissues, broken down, and it will go into the liver, and liver becomes fatty liver. Fat from the subcutaneous tissue will be mobilized, means it will be broken down from the subcutaneous tissue and it will be taken to the liver for storage. So it leads to fatty liver. And lipogenesis is also low. What gives rise to fatty liver? Small molecules of fat is deposited in the cells of the liver. But these molecules are supposed to make new lipids in your body. Lipogenesis is supposed to take place out of these broken down small fatty acids. But that is not taking place. So what will these fatty acids do? That will just go and deposit in your liver, and that leads to fatty liver. So the pathogenesis in kwashiorkor, you can see here, protein requirement is not there through diet. Okay, child is malnourished, protein is not there, inadequate protein in the diet. That leads to less amount of ferritin and decreased protein in the body. Ferritin is another protein which is required to store iron within the intestine, to store iron within the liver. Okay, ferritin is required. It's a type of protein. And other forms of proteins are also decreased within the body. So what will happen when iron cannot be stored within the body? Hemoglobin will go down, decreased hemoglobin, HB is hemoglobin, and RBC production will also be affected. So that leads to anemia. And impaired lipoprotein. Lipoprotein means the protein which is supposed to move fat. Lipoprotein will help to move fat from point A to point B. But when there is no lipoprotein, because there is no protein in the diet, lipoprotein cannot be formed. Okay, so lipoprotein is not formed. Fat cannot be moved from one point to another point. These fat cells will get deposited in your liver. Okay, and that leads to hepatomegaly. Hepatomegaly means enlarged liver. Fatty liver can also turn into hepatomegaly, enlarged liver. So is it clear the pathogenesis? How you get hepatomegaly or fatty liver because of inadequate protein intake? So when you don't have protein in your diet, okay, there is no way ferritin can be formed in your body. There is no way lipoproteins can be formed in your body. Okay, to form all these proteins within your body, amino acids are required. That comes from protein from diet. When there is malnourishment, no adequate protein in diet because of malnourishment, okay, ferritin cannot be produced, lipoproteins cannot be produced. If ferritin is not produced, who will store the iron? There is nothing to store iron. So iron will be lost from the body. If iron is lost from the body, there will be iron deficiency, because of which you will get less hemoglobin in blood and you will turn anemic. Okay. Again, other forms of protein is not available in the body. Who will make lipoprotein? If lipoprotein is not made, there is nothing that can transfer fat from point A to point B. If fat cannot be transferred from point A to point B, it will get deposited in your liver cells during circulation, blood circulation. Okay. When there is too much of deposition of fat cells in the liver, it leads to fatty liver. And fatty liver will lead to hepatomegaly. Hepatomegaly means enlarged liver. Liver will turn bigger in size as its normal size because too much of fat depositions are taking place, because there is no lipoprotein to move this fat away and take it to wherever it is required. Is it clear now? So coming to pathology, pathology of proteins during kwashiorkor. So some proteins are naturally low because in diet it is low. Serum albumin level, blood protein levels will become low. Okay. Serum globulin is normal. There are two types of protein in blood, albumin and globulin. So albumin becomes low, globulin is about normal. But serum albumin level is maintained in marasmus. So albumin, it falls, the fall in serum albumin is seen only about in 3 weeks later due to adaptations. Okay, the child has to be malnourished for more than 3 weeks. Then you will see reduction in the serum albumin level when you do the blood test. By 50% reduction will be seen. Then globulin level, that could be normal, but in serum protein electrophoresis, in which protein is made, okay, globulin can be increased in malnutrition, but in marasmus, the globulin level falls, serum albumin level stays normal. And there are different types of globulin, alpha 1, beta globulin, gamma globulin. So different types of globulin react differently when it comes to kwashiorkor cases. Amino acid pool, again, all the amino acids come down to 50% than normal. Essential, non-essential ratio, okay, that will increase because essential amino acids are coming down, non-essential amino acids are increasing. Normally, essential, non-essential, essential amino acids should be, the ratio should be 1.5, but when you are dealing with a kwashiorkor case, you will see this ratio is 3.5. Leucine, isoleucine, tyrosine, 309, these all are essential amino acids that will come down. Aminogram can be done. It's a test. Plasma aminogram test is done in malnutrition to check at what is the degree of malnutrition or kwashiorkor the child is suffering from. Coming to carbohydrates, glycogen reserves in the liver and muscles get depleted in both the cases. In marasmus and even in kwashiorkor, glycogen, that is carbohydrates, will be depleted. And when the entire stores are depleted, there are chance of hypoglycemia. That means the blood sugar levels becomes low. But if 70% of the glycogen is depleted, okay, that can become fatal. You have to increase the glycogen levels. Lipids, the lipid liver, the fatty acid in the liver, it becomes 40%. 40% of the body fat get deposited in the liver. So just imagine what kind of an hepatomegaly you have to deal with here. 40% of the wet weight of the liver could be because of just fat deposition in kwashiorkor. Serum lipids, that is the lipids in the blood, that can become low because majority of them is getting deposited in the liver. So the serum lipids, blood lipid levels, that can become low. Electrolyte imbalance will be there. There will be increase in sodium, decrease in potassium, because of which sodium leads to retention of water. And in kwashiorkor, you will see edema because high level of sodium is present in the body. Potassium levels are falling down. Water, total body water increases, increase in the extracellular fluid and intracellular fluid ratio. More fluid is seen in the extracellular side, less fluid inside the cells. Outside the cells, you will see more fluid. Minerals like iron, zinc, magnesium, copper, calcium, phosphorus, and also other trace elements, they all will become decreased. Endocrine glands, most of the endocrine glands show general atrophy. All the glands will become smaller in size: pituitary gland, thyroid gland, thymus gland, pancreas. Okay, all the endocrine glands will become smaller in size, and because of which the hormonal secretion will also be impacted. All the hormones secreted by the endocrine glands will also reduce in number, in quantity. And this was known when post-mortem was done, autopsy was done in children who were severely malnourished. So through that, it is recognized that all the endocrine glands have undergone atrophy. Atrophy means decrease in size and the number of cells. Heart, usually the heart rate slows down. Okay, microcardia, which is less, the size of the heart is also smaller. Cardiac output decreases. ECG will also give changes of microcardia. Microcardia means smaller heart size. Cardiomegaly. Liver shows fatty change starting from the periphery to the center. From the sides of the liver will get the fat deposition first. Then the fat deposition will slowly infiltrate into the center part of the liver as well. But first, the periphery, the sides, the edges of the liver become fatty. Then the central region will become fatty. Then the gastrointestinal tract, GIT, all the mucosal lining of the GI tract will undergo atrophy. Okay, there will be not enough mucus secretion, and because of that, absorption will of further nutrients will also be affected. More deficiency will be seen once the mucosal atrophy begins. Bacterial overgrowth is also seen in few cases. Means that the gut bacteria, they themselves can cause infection to the patient. So these are the pathologies seen in Kwashiorkor and marasmus cases. The immunity and the effects of malnutrition we will see in next class. Next week, most probably class will